Okay, y'all, we're going to go ahead and get started. So thank you all so much for being here. This is the very last seminar in the entire lecture series. All of this will be recorded, and so if you miss anything or if there are any previous lectures that you want to go back to, they are all recorded as well. But with that, we'll go ahead and get started. So this seminar is called A Path Forward, the Future of U.S. Health Insurance. A reminder to sign in. And yeah, as always, I want to give a shout out to all the people up top. They had everything to do with putting this lecture together. So this was certainly a team effort. And then this is just the sign-in form again. But this is also very, very important. And so I'm so sorry, but I'm going to look at all of you, take out your phone, and at least just get the QR code. There are technically 6 questions, but really it's only 3. We're just asking before and after, how you feel about this lecture. And we really, really want your feedback because we're going to do another version of this series later in the summer. And so if over Zoom, you also are able to use your camera to get the feedback form, that'd be very helpful. And it will be linked in the chat. Great. Oh yes, and for the people who just walked in, if you don't mind please signing in, that'd be very helpful for us. I think, hold on, because I don't know if you got the, yeah. Great. So this was the entire lecture series. This is our very last installment. I'll give a brief overview of kind of the high points that we covered from each lecture. But as a reminder, we started with an intro to the basic concepts of U.S. health insurance. We talked about privatizing efforts that are happening with our only national public insurance program, Medicare. We talked about labor organizing, both in the second lecture and also in the third lecture, when we covered COVID-19, how it affected health outcomes, and how it affected organizing at large, specifically through the channel of labor organizing. Last week, we covered the universal health care in 2 different countries and the advantages and disadvantages of those systems. And then finally today, we're going to be talking about, first, we have an amazing guest lecturer, Dr. Rachcel Madley. She was formerly part of the Students for a National Health Program chapter when she was in graduate school. She is currently a health policy advisor to the U.S. Representative Pramila Jayapal, who is kind of the front line for Medicare for All legislation. And she's going to be talking about state and federal strategies for universal health care policy. Just as a little context, right now, what we covered last week and weeks previous is that Texas ranks dead last in terms of accessibility to healthcare in this entire country, and this country ranks dead last in terms of the entire Western Hemisphere having access to health insurance. And so really what we're trying to think about, right, is expanding Medicaid is not Medicare for all, but it is getting people insurance. And so part of what we want to cover today is the idea of what are the strategies for materially increasing health insurance access for people right now, while also having a long-term goal or creating a system that ensures access. Next, we're going to have our superstar guest speaker, Rohit, talk about developing a framework for evaluating different strategies to increase access to care. And then finally, we're going to have a kind of DIY collaborative session where we're going to talk about formulating strategies for long-term advocacy in your own issue passion areas. I very briefly just want to cover some of the high points that we covered during this entire seminar series. So first, we remember that by default, we are uninsured in the United States. There is no constitutional right to healthcare. Other constitutions in the world, for example, South Africa, have in their constitutions a right to healthcare, but we don't have that here. And so by function of that, we have what I have termed a non-system. I want to remind y'all again that universal healthcare is not a system. It is a metric. It's an objective. It's the idea of having everyone within whatever geography having access to healthcare, having access to health insurance. And different countries have achieved that in different ways. As you can see here, the Canadian model represents one of the models in the United States. The UK NHS model represents one of the models, and then the German system is a different model. And again, I have here the point to remember that in our last lecture, we covered kind of the disadvantages and advantages of different systems that have achieved universal healthcare. And like any system, there are flaws, there are cons, there are things that need to be improved upon. But I like to include this graphic here because for the long haul, for many, many decades in the United States, most people have felt a need for fundamental change, fundamental differences. Something is rotten within our non-system versus opinions that have been in flux in other systems that require change, but can't really be compared necessarily to the way that we feel about health insurance here. We talked about the progressive tax and how single payer would be financed in this country potentially. And this is just a reminder of how in the current non-system where we have a flat regressive tax that taxes everyone equally within a company, just as one example, within employer-based insurance. So the CEO is paying as much as maybe a mid-level employee to get their insurance. Here, this is just a graphic to remind us of why it is that 92 to 95% of people would increase their net income if we were to implement the system, because you would be taxed less. Watch the lecture. This is just another reminder of how our health outcomes just frankly kind of suck until you get to age 65, when suddenly when you have access to health insurance, health outcomes change in the United States. We talked about how out of the 6.9 million deaths that have happened from COVID in the past 2 years, we are leaders in killing people from COVID. We have, without a national rigorous public health strategy, we have killed 1.117 million people with COVID. As a reminder, we are 4.25% of the world's population and represent 16.2% of all COVID deaths globally. And then finally, this graphic of our non-system, where by default, we are here. We are in the gray. And either you have private health insurance, you get Medicaid, but not equitably in this country, you have access to Medicare or different kinds of channels. What the ACA tried to do was make each bubble bigger. But what it did not do was guarantee everyone access to health insurance. Who did this leave out? Undocumented immigrants, plenty of people who are in that Medicaid gap, and kind of other people that, again, were covered more in other lectures. But this is just context to remind us of what all we have learned over the past 5-6 weeks. Okay. And so with that, I'm going to invite our lovely speaker, Dr. Rachcel Madley, to start.
Thank you so much for having me. I'm really excited to be here with all of you. And as was mentioned in the introduction, I was a member of Students for a National Health Program when I was in graduate school, and it kind of got me my start in working in Medicare for All. And so I thought I would talk about basically what was outlined in the introduction and start with, strategies and pathways of getting to Medicare for All. Because right now we have a presidential administration that does not support Medicare for All. They're on the record saying so. And so it may seem like there's not a lot that we can do to move the needle and get closer towards that policy. But if you look much closer at what Congress and the administration can do and are doing during this time, there's actually a lot that we can do to make progress. And we really see it as a time to prepare for when we do have the members that support Medicare for All in the Senate, in the House, and in the White House to be able to pass the bill. And so right now, I wanted to point out a few things that we have been doing within Congress that are definitely getting us closer to Medicare for All. I want to highlight that this is not getting us closer to Medicare for All as fast as we want it. So if the Congresswoman was able to make these decisions and push it all the way through, we would have had Medicare for All many years ago. But we do see meaningful progress taking place. And so the first thing I wanted to talk about was the prospect of lowering the Medicare age. So this is something that when we talk about Medicare for all, obviously the idea is to cover everybody as soon as possible. However, when we were negotiating the latest large bill package that focused on healthcare last Congress, which was called Build Back Better, what we were able to do is build incredible support for lowering the Medicare age to 50, 55, things like that. Now, this may seem like a very incremental step. However, we do see it as a way to, one, get more folks covered, and two, the way we were able to build support for this was making the case that public health coverage, such as what's in Medicare right now, is the way to go. And we must move away from private health insurance. And so what we did was we got very, very close to this being included in the package. We had over 50% of the Democratic caucus sign on to a bill to lower the Medicare age, including Representative Hakeem Jeffries, who at the time was in Democratic leadership, and right now he is actually leader of the House Democratic Caucus. So this idea permeated throughout the Democratic caucus, and what we did when we talked about it was base it on the fact that expanding health coverage is lowering health inequities. It's lowering our healthcare costs, and frankly, healthcare is a human right. And so by starting with this policy that was something that could be included in a package that was on the table, but using the evidence that we use when we talk about Medicare for all, we helped a lot of people get closer to supporting the policy. We built a bigger umbrella, if you will. Another way that we see moving towards Medicare for all and that thought that healthcare is a human right is pushing for immigrants to be included in our current public health benefits. So Congresswoman Jayapal leads a couple of different bills meant to remove the barriers that are placed on both lawfully present and undocumented immigrants that does not allow them to access things like Medicaid, the Affordable Care Act, CHIP, things like that. And again, underlying all of that work is the idea that healthcare is a human right. It should not matter where you live, what your immigration status is, what your income is, to the healthcare that you get. And actually just today, President Biden announced that he is expanding eligibility for Medicaid and the Affordable Care Act plans to DACA recipients. So that means that 580,000 more people in the US will have access to healthcare. Again, this is not our end goal, but we're taking the confines of the current Congress and administration and pushing it as far as we can while continually getting more and more people to agree that healthcare is a human right. Another thing I wanted to talk about, which I know one of your lectures talked about before, is Medicare Advantage. And so the traditional Medicare program is being privatized at a really alarming rate. And when you think about Medicare for all, this is scary because we need the traditional Medicare program to continue to exist and thrive in order to build the Medicare for all system off of. And so if we wind up with a fully privatized Medicare system where those private Medicare Advantage plans have taken over, it is going to set us back years in the fight for Medicare for all. And so recently, while we're fighting for Medicare for all, we've also been fighting against Medicare privatization. And for those of you who don't know, right now in traditional Medicare, private insurance companies, think Cigna, Humana, Aetna, can sign up to administer Medicare benefits if a Medicare beneficiary chooses. Now, what's not really known is that these insurance companies are price gouging the government, and this leads to billions of dollars in overpayments from the Medicare Trust Fund to health insurance companies every year. And this sets up a dynamic where the Medicare Trust Fund is facing insolvency and is getting drained while health insurance companies are getting richer, are getting more powerful. And that's exactly what we don't need to build Medicare for all. And so Congresswoman Jayapal has led various letters and briefings and educational events to try and raise awareness about this. And we recently led a letter with 70 members of Congress to President Biden, urging him to crack down on the profiteering of Medicare Advantage companies. And recently they made an announcement that they are going to start taking steps to do this. Now, they're not going as far as we wanted, so we will be continuing to push them on this. But it marks the first time that a presidential administration had admitted that health insurance companies were profiteering within the Medicare Advantage program, which is a significant step, because if you have been paying attention to health policy for the past years and decades, the health insurance industry and the pharmaceutical industry rarely lose when they're trying to get the policies that they want passed. And this marked a spot where they lost. They are going to see their profits decline. And that's a huge obstacle that we overcame. We have a lot more to do, but the tides are changing. And so in terms of pathways to Medicare for all, I think we have to be doing two things simultaneously. One, we have to build support for the core Medicare for all idea that one, healthcare is a human right, and two, we should have a single payer healthcare system in the US. And we have to continue to build that support, refine the bill, make sure it's ready to go when we get to that political moment where we have enough senators, enough members of the House, and a president who support Medicare for all. But at the same time, we have to keep pushing the envelope right now of what's possible to get us even closer there. And so that's what we're trying to do really in Congress. Now, there are also other pathways to Medicare for all besides the federal bill, and that is state-based pathways. So there are many states across the US that have single-payer healthcare bills in their state legislatures right now. And there is also a bill in Congress called the State-Based Universal Healthcare Act, which is led by Representative Ro Khanna, and that would make it easier for states to implement such a plan. And when thinking about state pathways to get towards Medicare for all versus federal pathways and the federal bill, Congresswoman Jayapal and our team really see these efforts as working in concert with each other, because whether we're talking about a state bill or a federal bill, we're talking about the same idea. The idea that everyone deserves healthcare coverage at no cost at point of care, and it should be streamlined and optimized in a way that only a single payer healthcare system can deliver. And so whether it's state-based or federal-based that we're advocating for, we're always moving closer to the idea and the reality of getting to Medicare for all. Now, I want to talk a little bit about the process of the bill in Congress and ways that you all can interact with Congress in advocating for Medicare for all or other issues that you feel strongly about, because there's a lot of places that the bill will pass through that people have a chance to raise their voices on, and sometimes they're hidden behind the curtains of Congress because there's so many things that go on and it's very difficult to know the procedures that happen in Congress. So the first thing that happens is a bill is introduced. So last Congress, we introduced the Medicare for All Act. This Congress, we're working on reintroducing the bill. And when we are talking about introducing the bill, the main point of input is asking members of Congress to co-sponsor the bill. And so in our office, we reach out to all of our Democratic members, offering them the chance to become a co-sponsor of the Medicare for All Act. And last Congress, we got to a record of 120 co-sponsors on the bill, more than 50% of the House Democratic Caucus. And this Congress, we're looking to grow that number even more. Now, once a bill is introduced, the next thing that can happen is it will have a hearing in a committee of jurisdiction. So there are many committees in Congress, and these committees focus on different issues. And since Medicare for All is such a large and sweeping bill, there are actually 9 committees that have jurisdiction over the bill. And these committees have jurisdiction over different parts. And so we essentially want to build the record of support for the bill within the committees that have jurisdiction over it. So how we do that is by asking committee leadership to hold hearings on the bill. Now, what a hearing does is it brings in witnesses who are experts on the bill, such as physicians, such as health economists, patients, and everyone that Medicare for All would affect. And then members of Congress get to ask those witnesses questions about how Medicare for All would improve the healthcare system. What are the concerns with the bill? Things like that. And it really just allows members of Congress to show their support for the bill. And it's one step that is typically required for a bill to move forward, because again, in Congress, it's really important to debate ideas before we move them forward. So far, we have had hearings in 7 of the 9 committees of jurisdiction on the Medicare for All Act. That is a large feat in and of itself. And we are only able to hold hearings on the bill when the Democrats are in the majority in the House. So unfortunately, this Congress, there will likely not be any hearings on the bill because the Republicans have the majority in the House, so they get to decide what we have hearings on. That does not mean that we are going to stop asking committees for hearings. We are going to continue talking to the Democratic members of these committees so that once we get back into the majority, we can have additional hearings on those bills. And that's another way that a lot of times outside groups let their voices be known, is by talking to members of the committee that have jurisdiction over the bill that they're interested in and letting them know that they want to see the bill considered by the committee. Now, after a bill gets a hearing, it will get what's called a markup. And this also happens in the committee of jurisdiction. Now, a markup is essentially a debate on the bill just between the members. So there are no witnesses here. It's just the members. And it's a time that members can amend the bill. So think of it as almost bringing a red pen to the bill and adding things and taking them out and really fine-tuning the bill. This is the step that happens right before a bill goes to the floor for the vote. And so a markup is really important for a bill. We have not had a markup of the Medicare for All Act yet. And that is simply because there has not been, frankly, enough support to get a floor vote on the Medicare for All Act. And so if we think about it, we've had a lot of hearings on the bill. More hearings are always going to be beneficial. But the real next step for the bill, once we have the majority in the House back, is going to be a markup. We want to see this bill moving forward. And that's another way that outside groups often let their voices be known. They'll contact staffers like myself and tell me, hey, we want to see a markup on X bill. So that's really the next step. After a markup is concluded, if a majority of the committee members vote to send the bill to the floor, it can technically be brought up for a vote. Unfortunately, this doesn't always mean that it definitely will get a vote, because there are thousands and thousands of bills in Congress that get introduced. There are hundreds that get marked up, but there's a limited amount of time on the floor for votes. And so after your bill has a markup, if that's successful, the next thing that you want to focus on is making sure that House leadership knows how important it is to have a vote on that bill. And so that's another area where, as the bill sponsors in our office, Congresswoman Jayapal, if the bill were to be marked up, would be pressuring House leadership and urging them to have a vote on the bill. So I wanted to go over that because I think it's often hidden, and we call it wonky on the Hill. It's kind of misunderstood how a bill becomes a law, rather than just focusing on, passing the House, passing the Senate, and going to the president. There are a lot of steps that happen within each chamber, and it's really helpful to know so that you know when you're advocating what you're advocating for. And so there are a lot of different things that clearly you can have input on. And so we have also seen, and the Congresswoman has also used other tools to raise awareness for the bill. So that can include op-eds talking about why we need this bill. They can either be in national news outlets or state and local news outlets, which are also very helpful because there are a lot of readers for those outlets as well. And the final thing I wanted to talk about is, and I think this pertains specifically to Texas because the state is struggling with, getting Medicaid expanded, but also there are a lot of folks in the immigrant communities in Texas who frankly do not have access to public health benefits, even if Medicaid were to be expanded. And so I wanted to highlight another thing that we're working on, because within the Medicare for All bill, all residents of the US will be covered, regardless of documentation status. And we need to be building support for that idea as well within the Democratic caucus. And so the Congresswoman leads two bills that would remove all of the barriers and bars on immigrants accessing healthcare. Right now, undocumented immigrants cannot access Medicaid, CHIP, ACA, things like that. A little known fact is that lawfully present immigrants are also barred from accessing public health benefits for the first 5 years that they're in the country. And so that's something that we want to totally remove in Medicare for All, but we also have standalone bills to do this because those are things that House leadership has expressed interest in, and we could move right now that would get us closer to Medicare for All. So I wanted to highlight those bills. One is called the Lift the Bar Act, and the other is called the Heal for Immigrant Families Act. And I wanted to highlight that because I think it also goes into the idea of building momentum towards Medicare for All to eventually get there and work on improving our healthcare system until we get there. And so I will pause there and would be happy to take any questions from either people on the Zoom, if you want to throw them in the chat, or in the audience.
I'm happy to come bring the mic forward if anyone has a question, or we can also provide, but I'm going to give a minute. Yeah, I'll come there.
A lot of what you said was like very important, and I think it was like a little difficult to understand. So I'm just wondering how to make this information more accessible, especially for like undocumented communities and people who would actually access these services. Because I know like bureaucracy is very hard to understand, especially for someone who doesn't speak English.
That's a great question. And I think one area that can be helpful, especially as future medical providers, is to talk to your patients who may be in these communities where there's a lot of barriers to healthcare, and make sure that they are up to date on all of these changes, because I think that's such a great point, right? It's, I know that the Biden administration expanded eligibility for Medicaid and ACA through DACA because that's my job and I get, the email alerts and things like that. But people who actually need this care are not getting that alerts, and it's not being communicated to them. And so I think one way to do that is, as future medical providers, try to stay up to date on these things so that you can let your patients know when it applies to them. And the other thing that Congresswoman Jayapal has been trying to do a lot is make sure that we as lawmakers are disseminating the information. And so we put out a statement on the announcement about what this means for people in the DACA community, how they can access these benefits, and we'll also likely be adding things to our website. And we try to encourage lawmakers throughout the Democratic caucus to do things like that. So the Congresswoman is the chair of the Congressional Progressive Caucus, and that caucus has over 100 members. And so what we'll do is we'll send out resources of how to make these announcements and developments in health coverage accessible and understandable to the people who need them. And so it's all just about continuing those educational efforts. And I think as future physicians, you all can be helpful in that.
First, thank you for giving this talk, but I wanted to ask about like bipartisanship. Like, does your office do anything to try to find maybe some of those outliers on the Republican side that could express support for this, or are there any attempts to do so? Just because it seems like it's not the most effective if you have to wait for like a majority, right? Like we could be doing something now. So I just wondered like what y'all do with that.
That's a great question. So on Medicare for All, there is bipartisan support from voters. So we know through polling that actually over 50% of Republicans support moving toward a Medicare for All system. Unfortunately, that doesn't translate into Republicans, members of Congress supporting the policy. Now, we do try to work in a bipartisan manner whenever possible, because exactly to your point, you don't want to have to wait around until you have a Democratic Senate, House, and President to be able to move things forward. Unfortunately, on Medicare for All, we have not been able to find a Republican who is supportive of the bill and willing to go on record and support it. There are other things that we have been able to do, but in a bipartisan way, that I think are moving us towards Medicare for All. One example of that is a bill called the Stop Anti-Competitive Healthcare Act that Congresswoman Jayapal led last Congress with Representative Victoria Sparks from Indiana, who is a Republican. This bill essentially will stop allowing hospitals to merge and consolidate with no oversight. So right now, the Federal Trade Commission has oversight into companies that are merging. If, let's say, Amazon and Walmart wanted to merge, they have the authority to stop that merger because it creates a monopoly and drives up prices. In healthcare, hospitals that are nonprofit, which is most hospitals, do not have any of that oversight. So they can merge with whoever they want. And what we're seeing is hospitals are merging into these giant systems, and it leads to an increase in price and a decrease in accessibility. And so that is something that we're really excited to be working on in a bipartisan manner. And with most of our bills, we do reach out and discuss if we can make it a bipartisan bill, and some we're able to, like the hospital bill that I mentioned. Some we haven't been able to yet, but that doesn't mean that we wouldn't try or be open to a Republican co-sponsor on Medicare for All.
I want to give one more thank you to Dr. Madley for speaking so amazingly on what's going on federally. We do have to move on for sake of time, but I love the fact that we have questions, and you can even put them. We have one in the Zoom chat, but we'll try and save time at the end. Just for now, we're going to move on to the next section. I just want to summarize some high points. So pop quiz. Does anyone remember how much we spent on health insurance or healthcare in the United States in 2022? Any guesses? This is for anyone. How much money did the US government spend in 2022 on health spending alone? Throw out a random number. 5 million? So close, so close. 4.3 million. And we are projected to spend wait, did you say, what did you say? Oh, not close, sorry. So sorry. Actually, it is $4.3 trillion. I don't know if y'all know how many zeros that is. I don't know off the top of my head. One thing this is an amazing case example of this, of million and trillion in our language is like the difference of a phonetic way to pronounce that word. And that is not what in a dollar amount, a million versus $1 trillion is. And I try and emphasize that because all of the facts, if our health system were a country, it would be the 4th biggest country in the entire world, Maybe that would make sense if we had the best health outcomes in the world. We don't. We just don't. And so I really encourage y'all to maybe try and go back to the first lecture, just because I think it gives a lot of context for the awesome questions that y'all are asking of what is happening, what are our opportunities to intervene. The two main points that we wanted to take away from this seminar series included: one, what is the health policy content itself? What are we supposed to know off the top of our heads to allow for change? That includes things like how much our health system costs, how it ranks against other health systems, what are the who is lacking access, whether that's undocumented immigrants or documented immigrants like we talked about today. We talk about how a lot of people who are uninsured, the majority, are family systems that have one full-time worker. So just kind of remembering who are the people that are affected by our non-system. The other section of learning objectives that we wanted to kind of provide, and I hope to get y'all's feedback on this, is what is organizing? What are our advocacy efforts to try and change things? And some of the awesome content that we received today included legislative advocacy. And so what are the points of access when the bill gets introduced, when the bill gets marked up, when the bill gets to a hearing point? What are the ways that we can try and intervene? We had talks about bipartisan support, things like that. Those are all really important. Some of the last things that I want to mention before I hand off to our next speaker include kind of ways to evaluate, and we're going to talk about this in the next section, ways to evaluate strategy, right? So there's defensive versus offensive strategy. Some of the defensive strategy that we've talked about in the seminar series includes protecting Medicare, protecting it from the privatizing efforts that are ongoing, that are relentless. We just had a recent win, as Dr. Madley pointed out, with basically what has happened with the Medicare Advantage profiteering and the idea that the health insurance companies lost on that case. So that's kind of on the defensive side, is protecting what we have. Then there is the offensive side, and that has many layers. There's a city level, state level, federal level offensive side that we can try and do. And so that's some of the stuff that we're going to bring up today. Spoiler alert, there are opportunities to get involved on a city level as well. And so I really hope you all pay attention to Rohit's awesome lecture because we'll think about different strategies for change.
Okay, cool. So just like Yosha mentioned, something that helps me a lot when you hear a lot of different proposals for reforms in healthcare, whether they're, people present them as stepping stones to Medicare for all, whether they're whatever they are, you have to be able to understand what they mean and determine whether or not those are actually going to be helpful in the long run towards achieving our goal of universal coverage, or if they can actually detract from that and harm those efforts. So really, I took a lot of this from this working paper from the National Bureau of Economic Research. Put a QR code up there, but I think it does a phenomenal job of laying out the different ways in which the United States has traditionally approached reforms to achieving universal coverage and why those have not been really successful in doing that. And so kind of getting right into it, basically the paper outlines two approaches to achieving universal coverage, either addressing market failures or providing a social floor. These are kind of the two frameworks with which you can approach a reform in healthcare to achieve universal coverage. So kind of walking through the first one of addressing market failures, it relies on the presumption that health insurance is a free market problem. It's a problem of supply and demand. The supply being the insurance and the demand being the patients. And so by that logic, when you have people who are uninsured, it's viewed as essentially just an inefficient distribution of goods and services, a mismatch between the supply and demand. And then you just figure out, if you're operating under those assumptions, why is there this mismatch? Why do the supply and the demand not align? And then you just iterate. You have incremental reforms that you try to address those specific failures that you believe are driving this mismatch between supply and demand. And this is the way in which the United States has traditionally approached health reform. And really, any major reform we've seen over the past couple decades has been in an attempt to address a perceived failure of the market. And so this is kind of the constant approach where we keep trying to figure out something that's a little wrong, fix it. Find something that's wrong, fix it. Find something that's wrong and fix it over and over and over and over and over again, with the end goal of, in theory, having this implicit idea that we are going to achieve universal coverage this way, but never explicitly stating that that is the goal. Now, providing a social floor, on the other hand, it resides on this baseline assumption that establishing universal coverage is the explicit goal of this reform. So whatever you bring out a proposal, it relies on the basic presumption that your end goal is universal coverage, and that is the base from which you are approaching anything else. So if you adopt that mentality, then the first thing you do is you define a basic bundle of services. You figure out, okay, if we are going to cover everybody, and that's what's going to happen, what are we going to give them? That's what we're going to include in this framework, like the basic bundle of services that are going to be included for everyone in this program. And then you figure out, okay, we've given everybody coverage, we've figured out what we're going to give them, and now we're going to figure out how we're going to make sure that we're not spending insane amounts, and make sure that we know how to govern this program. But this is only after you've established a program with the baseline assumption that you're going to give everyone coverage. And then finally, this one that they outline in the paper, just outlining supplementary coverage options, if any. We'll get into a bit of what that means. But I really want to illustrate how these two approaches have played out in reforms that have happened already and reforms that are being proposed. So first, a market failures approach being the Affordable Care Act, which was heralded a lot as being a transformative way to fix healthcare in America. And yes, it did cut into the number of uninsured people in the country, but there's still a lot of uninsured people in the country. We can see how it's taken a market failures approach and it's tried to gnaw away at that, but it's still not really gotten us to our goal of universal coverage. And so these two are kind of outlining, again, the basic premises of this market failures approach that I talked about. And then this is how they approached it. I don't know if where'd it go? There it is. So basically it said, here's the failure that we're trying to target. It says that people are not insured because it's just cheaper for healthier people to not be insured. That was the assumption that they made when they looked at the market. Another thing that they did is they realized, it's kind of hard for people to get insured, and sometimes they don't really qualify for certain programs. And they viewed these things as essentially just failures of the free market in healthcare. And so their solution to that was things like the individual mandate, things like Medicaid expansion, things that in theory were supposed to address these specific problems, not supposed to bring coverage to everybody, but just intended to address these very specific problems. And you can see how with all of these things, yeah, they work to address those problems, but we still have uninsured people. These things haven't really been enacted in their full form for various reasons. And because of that, we still have uninsured people in this country. Now we can look at Medicare for All and how it's a social floor approach, because the baseline premise of any Medicare for All proposal is that everybody should be entitled to baseline health coverage. And that is the very foundational premise with which all Medicare for All proposals are built off of. And we've said that coverage should include some basic things like hospital care, emergency care, drugs, various other things, various proposals you'll see will define their basic bundle in different ways. But the ultimate premise being we're going to give everybody healthcare, and we're going to define what we give them in slightly different ways. But no matter what, we're going to give everybody healthcare. And the same things now. Now we look at in these proposals, how are we going to reduce costs? How are we going to govern these programs? Things like lowering prescription drug costs, eliminating corporate lobbying, like Dr. Madley just talked about, hospital antitrust laws, investing in preventative care and public health, and then delegating the administrative authority to some form of public entity, such as for Medicare services, to run these programs. And then finally, if you're interested in this last part, go listen to, lecture 2, where you talk about what these things should cover or not. So things like Medigap programs, dental, which that's getting into like the weeds a little bit. But generally speaking, you can see how any Medicare for All proposal is built upwards from the basic assumption and basic premise that everyone should have healthcare. Whereas things like the Affordable Care Act really wasn't built upon that premise. It was built upon addressing very specific issues and challenges in the current free market space of healthcare. And so now I want to kind of pose a question to you all. Can incremental market failure oriented reforms ever achieve universal coverage, or do they actively hinder success? And this is the point I really want to hit home, because you can see how when you take a different mentality to approaching health reform, you're just kind of chipping away at this problem without really addressing the underlying premise, and you're not making explicit your goal of giving everybody coverage. And when you're doing that, all you're doing is delaying progress again and again and again without explicitly laying out what you hope to achieve. And so things like the Affordable Care Act, again, heralded as this amazing transformative reform, really did not get us to universal coverage. And so this is the question I want you all to think about. Basically, just if we have these incremental reforms over and over again, could they actually be getting in the way of really achieving universal coverage? And then the last little promo. Yosha and I wrote an op-ed published this morning in the Austin Chronicle. There's a QR code. Please read it. Where basically we lay out kind of some of these premises of why Medicare for All is really important in Texas, especially, and why right now is kind of a really transformative moment for it. But yeah, before I pass it over to Yosha, questions? No? Cool.
Congratulations on this op-ed. And you talk about this in the op-ed, but I want to actually ask you the question back, Rohit, from one slide ago, and hear what some of your thoughts are about sort of an incrementalist market failure approach, and does that hinder success in longer term universal coverage or Medicare for All?
Short answer, yes. Because I think essentially what happens is, if you remember the picture that Yosha put up earlier with like the big gray rectangle and all the little blue bubbles in it, a market failures approach is just going to try to increase those bubbles. And then you can kind of just see when you're trying to fit like essentially like a round peg into a square hole type of situation, you're always going to be left with those little cracks. You're always going to have people falling through the cracks. And you're not really ever going to get to that universal coverage, because every reform you make, if it's not done with the explicit intention of providing healthcare to everybody, it's not going to get there. And what happens when you only invest your time in these market failures reforms, you have to give time to see if it works. You take time investing in that, and you never actually lay out your explicit goal of universal coverage. And so what happens is it kind of just kicks the can down the line over and over and over and over again. And you keep identifying, oh, maybe it's just a problem with this little thing. Maybe it's just a problem with this little thing. But you never will really get to universal coverage that way, because you're going to keep having these cracks. You're going to keep trying to address them, and then you're just going to keep having more and more cracks. So I really don't think that if we keep going down this path of market failure, address it, market failure, address it, that we're really ever going to get to universal coverage. And really the only way we can get there, from my perspective, is really setting that from the get-go in any reform that we do, that this is the goal, and we're going to base the system around that.
We have one other comment.
Thank you. I'm just wondering, do most sort of incarnations of Medicare for All proposals, like what is the space that's left for, if any, for, I mean, I'm imagining taking all this gray area in this thing and saying, okay, no, all gray is, select color, turn blue. Like we all, the explicit goal is that everyone has coverage. And then is there space in that system for private insurance and providers to still exist on top of it for those who want it? I know that there's that's kind of how it works in the UK, we talked about at one of the other lectures, and I'm curious about how proponents of Medicare for All feel about that, and what role that would play for people who, I guess, want to opt for a market-based approach to insurance on top of the premise that everyone should be covered. I'm just curious. For either of you.
I'll try and address that. Okay, so that's a great question. Maybe I'll go to this slide. Yes, so Medicare for All most models the Canadian health insurance system. So like was mentioned, within the NHS, the UK system, essentially the way that you access healthcare is you go through a GP, a general provider, a family medicine doctor, and they kind of, bring you to a specialist, and that's the main public approach. And if there is reason for wanting private health insurance, then you skip that pathway and you have a different pathway to go down the private health insurance market. And within the public sphere, that is all a global budget given by the government that kind of funds the public end, and the private end operates separately. So within that system, there is opportunity to have private health insurance. There is also opportunity to have private health insurance within the Canadian model. To be honest, I don't know the ins and outs of it. Like, I'm more familiar with the NHS system. And the other kind of asterisk I would give here is that the 2023 federal Medicare for All bill is going to be filed in May, June, which brings us to our next point after this. But that will have more explicit language, I assume, about these kinds of questions. So I would say, one, I don't totally know. But two, I know that because Medicare for All most models the Canadian model that does have room for private health insurance, my imagination is that yes. And in May or June, I'll probably read up on that and maybe send the SNAP serving list or the SNAP email list that I hope you all join to maybe get more clarity on that question. So with that, I think we're gonna, yes.
And one quick note on that question too is, again, if you look at kind of these steps that are laid out in the way that you approach Medicare for All or single payer system, there's flexibility within that. Like, what do you define in your basic bundle? How do you define supplementary coverage options? So things like Medigap, things like private insurers can play a role in that. Whether they should or not is a different question, but they can in theory. And I will also say there is an interesting book, if you ever have the time, Catastrophic Care by David Goldhill. I wouldn't say I necessarily agree with everything in there, but he essentially lays out a universal coverage plan that involves private companies, factors, motivators, whatever. So it is a possibility. Again, whether or not it should be, different question.
Which now for this next, like 5-10 minutes, because we started at 12:35. We're going to make this a lot more participative. And I kind of want to address the very first question that was asked that I thought was really important about, okay, all of this information, low-key kind of convoluted, like what do I do to get that to be accessible to people? And so part of what we want to do here is remember that organizing is an advocacy modality separate from legislative advocacy that is ongoing, that is sustainable and ongoing. And part of the point of this lecture series also is to remember that because I care about this issue, have data on the top of my mind. $6.3 trillion to be spent projected by 2030. We are 11th out of the 11 OECD countries ranked in terms of our health outcomes and our health system. In fact, when the Commonwealth Fund was trying to find averages of the 11 countries, they had to take the US out because it was such an outlier to the data. That is how far apart or how different we are from every other health system. Those are facts and data and pieces of evidence that are in my mind. And the reality is that doesn't do anything. That literally does not matter. Knowing this data is not enough. The Physicians for a National Health Program, which is what is the sister adult job kind of organization to the Students for a National Health Program, has for years collected data, evidence, it described what are the opportunities to intervene. And the reality is that we have made headway, but we are not there. We have not passed the bill, as you can see. And so what can we do in the face of that? What can we do in the face of that? So part of the answer that I argue through this series is that you have to build relationships with people. And so the people who are affected by this, including undocumented immigrants, as we talked about, as kind of like the case example right now for how incremental change isn't helping. Frankly, meeting them one time at the clinic and telling them, hey, it sucks that you don't have health insurance. These are some, like, I'm contacting my social worker who works in this clinic, and here are some opportunities for you. That is getting them access to a service, but that is not organizing for change. That's not bringing them into this movement. And that's kind of what we want to do here, is bring people into a movement, give you the data, give you the facts, give you the reason to believe cognitively why this matters. But none of you are going to get up and do anything if the only thing that we do is talk about basic evidence. So I want to exercise what I'm talking about by kind of pulling into what drives you all. So I don't have this written down, so maybe I'm going to go step by step with this. But first, I'm going to describe to you basically how I envision what organizing looks like for the issue area that I care about, and then we're all going to have a little interactive moment after that. So what do I care about? Having people have health insurance. I care about everyone having universal health access. So if that is what I care about, the first thing that I asked myself when I was thinking about this lecture series was, who is my community? Who am I accountable to? Who can I influence? Who cares about me? Who do I care about? And the very first kind of circle of people that I had considered were medical students. So I thought about people, I'm a third year medical student, as we know, and I thought about first year medical students. I thought about people within Dell. I thought about faculty. And that was kind of the basis point for when I was like, how can I influence these people? And since then, it's grown. Thanks to Rohit, we have all of you undergrads here, which is so useful, so helpful. And so I'm trying to expand that pie. First question, what do I care about? Second question, who is my community? How do I make that grow? And the third question is now, afterwards, what is the strategy for change? What is the strategy for getting something, getting material change out of the issue area? Some of the concepts that I described earlier included defensive strategy versus offensive strategy. So defensive being protecting the social services that we have, offensive meaning strategies for change. We talked about on different levels, on the city level, what can we do? On the state level, what can we do? On the federal level, what can we do? The federal level to me is the most convoluted, to be honest. And the people that are most proximate to me are in the city and state level. So on the state level, Rohit and I wrote an op-ed that got published in the Austin Chronicle with a viewership around, or a readership around 600,000 people. Will all 600,000 people read my article? I mean, hopefully, but no, right? And so, but that is one access point. On the city level, which, oh, it's right here, thank you. On the city level, we are trying to get Austin City Council to pass a resolution in support of Medicare for All. So I don't know if y'all are familiar with Vanessa Fuentes, the council member who has been doing a lot of work around Austin in like a progressive fashion. But we reached out to her office, and she is not just accepting, but is eager to get that resolution passed. And so either May 4th or May 18th, we're going to have a meeting with Austin City Council, and we're asking people to come provide testimony. And so if any of you are influenced by any of the evidence or data that we provided, and or have your own experiences with health insurance that have adversely affected you or your family members, this is an opportunity to intervene. This is an opportunity to come to the Austin City Council, state your case, and join the already 117 cities, now the 118 if we were to pass it, that support Medicare for All. So in summary, big picture, pick my issue area, pick my community, pick strategies to intervene on different levels. So I want all of y'all in maybe little like groups of 2 and 3 to pick an issue area, pick the people that you are in community with that you know you can influence, and then pick one strategy, whether that's based in the issue itself. Let's say it's passing Medicare for All. Let's say it's passing a city council resolution, or ancillary policies around it. So Dr. Madley talked about the idea of how undocumented immigrants and documented immigrants in the first 5 years, so documented immigrants in the first 5 years are not able to access social services, which is just horrendous and tragic. That is a way, that is a pillar to knock down. Is that Medicare for All? No, but that is like proximate to the issue. And so those are also different ways you can intervene. So now I'm going to shut up, and I'm going to let you guys talk in groups of 2 or 3 for, again, issue area, community you're accountable to, one strategy for change. And on Zoom, you can provide in the chat. I'm so sorry to cut you off short. I maybe like, you can wrap up kind of some conversations, but do we have any willing, brave participants to offer what they talked about? Oh, great. Yeah.
So we talked about how like because we're young people and like it's not that long ago when we were kids and probably a lot of us are still on our parents' insurance. I think expanding CHIP could be like to universal CHIP coverage could be a good step. And so we talked about like to do that, it'd probably make the most sense to connect to parents through like school teacher nights, like parent teacher nights type things to where you can show your parent, like the parents, hey, it could be a reality that your kid doesn't have to skip out on the physical or not get their glasses or whatever, and just like work through the community there and prove to them that like it could be a reality if you like talk to your legislators, write opinion pieces, and then hopefully like also getting maybe like teachers on board with that because they can see the impact of like kids not having care in their classroom, and then just like community efforts to write to the people in power that can actually do that, and just proving to people that like this is something that no child should have to like be uncovered because their parent can't afford it. Like we could make this like a right starting off with the youngest people.
I love that. Some of the things that I'm hearing include same issue area, the idea of health insurance, and then community-wise, having parents and teachers be involved is such an important kind of thought, considering how proximate they are to these issues. One thing that I would offer includes that Dr. Patel knows this. The Texas Harm Reduction Alliance recently had a great organizing win in terms of getting the city to pass or getting the city board basically to get bus passes for the unhoused, with a universal fares program hopefully coming out by sometime this year. And I say hopefully because the idea is that, like you're saying, it is kind of a two-part process. One is getting your base together, whether that's parents, teachers, other like people who are directly affected by these issues. And then the second step, like you mentioned, is approaching people with power. One of the things that we want to outline again in this lecture series is the idea of what is power. And power comes from the idea of having a group of people band together to pester the people with resources. And so it's not only the people who are gatekeeping the resources that have power, it includes the community members, the 99%, the people who are affected by the issues to come together, because there's more number in that than there is by people who are gatekeeping. So I love that. Are there any other examples that we would want to share? It doesn't have to be health insurance. I know that's my issue, but. Great, thank you.
Okay, so I feel like my classmates pretty much know this because I always talk about it, but I'm pretty passionate about giving back to my community, which is Del Valley, on the outer skirts of Austin. And so it's a very underrepresented area in terms of food access. And then the geographic, like the way it's set up, it's like it makes it harder if you want to like walk or cycle to reach any food sources. And so that's my issue. My community is the Valley community because I have connections there as well where I could like voice out my concerns and my solutions or ideas. And then my community is also like my classmates here because I know we all have a lot of knowledge in that area. And then some of the orgs I'm a part of. And then the third one was solution. Jack actually gave me an idea when we were talking that I could bring it to like the council there because they have like community meetings pretty often. I could like intervene there and like bring my like again my ideas there and then network within the community as well and like hear their opinions as well and how we can move forward with change.
That is an awesome example. Thank you so much. So I'm just going to wrap this up just because I know that I've kind of gone over time. So sorry that we couldn't that more. But thank you guys so much for coming. I really, really appreciate it. I really, really hope that y'all fill out this feedback form. Again, it's only 3 questions, technically 6, but really it's a before and after. And I want to hear y'all's comments about how we can incorporate more solution-oriented education into these lecture series, because I really love y'all's questions. I think y'all are a really activated group, and that's the whole point of this, is to get activated people to do something. And so I'm so grateful that you're here. Please take food. Thank you to the Zoom people for coming, and that's a wrap.